Ma'am, you're muted.
Am I audible now?
Yes, ma'am. Yes.
Okay. So now you're aware of how to manage, the basics of the pain pathway, and step 1 and 2 and 3 also must have been dealt with by now. So now we will move on to the management of difficult pain. Okay. So I just share my screen, please. Can I share the screen?
Yes, ma'am.
Let's try again. Share screen. Okay. So I'll go on to my slideshow. So now today we are moving on to how to approach a patient with difficult pain. Okay. So we are all aware that the three-step ladder that we are routinely using to manage pain, and the third step is for the severe pain. But as has been mentioned earlier, the only about 71 to 76% of patients can have good relief with the third step of the ladder. So there is still a segment of patients who may be unresponsive to even the strong opioids. And that is what we call as refractory cancer pain. So the other terminologies for this are intractable pain, persistent pain, or opioid non-responsive pain. So what is the definition? It is pain related to cancer or its treatment of at least 3 months duration that has not responded to standard treatment with opioids and co-analgesics. So there are certain risk factors by which a patient is susceptible to get this intractable cancer pain. And this is younger age people, those with neuropathic pain, those with incident pain. Incident pain is when pain which happens on some movement or some activity. Then when there is a psychological distress, because we know that total pain concept, it's not just physical, it can be also psychological. Then if there is a previous opioid use, or where there's tolerance to opioid or history of addiction and impaired cognition, these are the factors that can predispose for patients to get refractory to the routine treatment of cancer. So let me start off with the case scenario. This is a 62-year-old man who had CA rectum, and he had peritoneal and liver metastasis. He was on chemotherapy since 1 year. Initially, he responded well and the PET-CT was favorable, but he then developed acute intestinal obstruction with pain in the abdomen due to progression of the primary lesion. He was taken to the ER and admitted for conservative management of intestinal obstruction. The Rayleigh tube was inserted, a colostomy was done, and he was discharged with the advice of continuing with palliative care. At that time, he was too weak to undergo any other treatment, including chemotherapy. Initially, he was taking step 1, 2 through the nasogastric tube, along with adjuvants for pain abdomen. But the pain persisted, and he was then started on the step 3 drugs, that is, a strong opioids orally. But one day he pulled out his Rayleigh tube and he did not want it reinserted. There was a family discussion as to how to feed him because he had become extremely emaciated and weak. But we decided, it was a mutual discussion, and we decided that we respect the patient's wishes and not reinsert the Rayleigh tube. So we allowed patient autonomy. The patient's wishes were respected. So we had no other choice, but there was a chemo port, so we started him on IV maintenance fluid. It did not take care of his caloric requirements, and the pain grew worse. And so, because he doesn't have a Rayleigh tube, he was started on transdermal fentanyl patch, 25 mics per hour, along with oral transmucil fentanyl citrate, which is OTFC. That is the fentanyl lollipops of 200 mics SOS. but there was no relief in pain and he was in excruciating pain. The family was extremely distressed. So what do we do to treat this patient's pain? So that is a case scenario, and we will discuss it after the presentation is over. We will see how we manage this patient. So if you look at steps of managing difficult pain, the first and foremost is to review the patient to see what could be the possible causes of refractory pain. And then we have to manage. And management involves both pharmacological and non-pharmacological methods. They are described here, but I will go through it in detail later. So when we look at the reviewing the patient, we should keep in mind the A, B, C's. There are two C's. The first is the patient adhering to the treatment that you have prescribed? The second is, we have to believe the patient about the pain. See, if you say, how do you measure pain? There is no measurement of pain like there's for temperature or anything like that. But there is a visual analog scale, right? But the best way of knowing how much pain the patient has is a self-report. So whatever the patient says, we have to believe the patient. And it was Margot McAfee in 1968 who said that pain is whatever the experiencing patient says is existing whenever he or she says it does. In simple terms, pain is what the patient says hurts. So we have to believe the patient that there is excruciating pain that is not responding to the treatment that we have given, even the strong ones. Then we need to do a comprehensive pain assessment. This must have been dealt with the assessment of pain, which must have been dealt earlier. So in which we go through the pain characteristics, the functional history, we review the prior drug history, we examine the patient and review the patient. So this is what we do, a comprehensive pain assessment again, because pain is something very dynamic. It's not static. What the patient had 2 days ago may not be what is there today. It's a very dynamic situation. And because of that, day-to-day assessment is very important. The second C is we need to correct the correctable factors. It could be, there could be an incidental pleural effusion or peritoneal effusion. There could be an underlying infection. There could be insomnia and anxiety or psychological distress, or so many other factors can worsen the pain. So we need to correct the correctable factors also. If you look at adherence to treatment, we need to first go through the prescription, review the analgesics, review the adjuvants, whether we need to add anything more. And also we need to see the patient's understanding of the dose regime, for which we use the teach-back techniques. So if this is a prescription of the patient, we should ask the caregiver and ask them to tell us what exactly are they giving. So many times I've noticed that even when we write morphine for Q4H, they are giving it 2 or 3 times a day or when the pain returns. Similarly, they may not be giving the laxative because they are worried that the patient will go in for diarrhea, or they may be not giving the sedative, or quite often they don't give the paracetamol, thinking the paracetamol is for fever, not for pain. So we must make them go through it and find out whether they are giving exactly what you have prescribed. Okay, if they're not giving, then we have to educate them about the prescription. Now, the most common reasons for difficult to treat pain are when you're giving opioids and there's accumulation of toxic metabolites, or when there's a progression of the disease. That's a very common reason why the pain has now become refractory. Or is there a new pain type? Is there now an element of neuropathic pain or bowel pain or spasticity? So then we have to add adjuvants, appropriate adjuvants. Or are there intolerable side effects with the strong opioids, like neurotoxicity? Or is the failed route of administration? Is there a poor oral absorption? For example, if the patient is landing up with intestinal obstruction, then you can't give anything orally, right? Or if there's a failed, the transdermal absorption is not okay. Or is there a pump or needle or catheter malfunction, particularly when you're giving IV, subcutaneous, or spinal opioids. So whether the route of administration is all right, we have to check. Then we have to change that route. And lastly, and very important is there psychological, social, or spiritual distress in the patient? That needs to be also managed. So if you look at the management of difficult pain, I said we have both pharmacological and non-pharmacological methods. Now, if the patient is on step 3 drugs, strong opioids, what are the reasons for opioid ineffectiveness? One is when the patient is developing tolerance to opioids, that we know tolerance is a very common phenomenon when you're giving opioids. And then, is there an addiction? Is there a craving for the drug? Is there only physical dependence? Or is there psychological dependence as well? Now, psychological dependence is addiction. Then we need to also educate the patient, make them aware of the drug that they are getting, how often they should take it, and if there is a breakthrough pain, how do you handle it? All that has to be explained. And then, of course, sometimes the drug is not available. Then you have to guide them as to where they can procure these drugs. So often they say that, we don't know where to get the morphine from. Then we have to tell them, that all licensed medical institutions can store and dispense morphine. For that, you need a special form. These things all have to be explained to them. Now, now we're talking about the pharmacological management. What are the pharmacological options for treating difficult cancer pain? The first is may need to do an opioid manipulation, which could be either conversion of the route or a rotation of the opioid, which is called an opioid switch. Or we may need to add adjuvant drugs like antidepressants, anticonvulsants, a whole lot of adjuvant drugs, which I've already talked in my earlier talk. So whether that needs to be added. Remember, I said pain is dynamic and there could be added factors at any stage of the course of the illness. Okay, so we need to do a daily evaluation to see whether there is a new pain type that has now added on. So first is what I'm talking about is route conversion. Now, that is, you're giving the same opioid, but you're using a different route. For example, you're giving still now oral morphine. Now, that is obviously not working. Patient is still having pain. You may have to switch over to IV morphine. Or you're giving a transdermal fentanyl patch. You may have to convert it into intravenous fentanyl infusion. So that is what is called a route conversion. Now, the route could be both IV or subcutaneous. They say that high serum concentrations can be achieved with both these routes. Both morphine and fentanyl can be given IV as well as subcutaneous. Just remember the conversion factor. Oral to subcutaneous to IV is 3:2:1. If you're giving 30 milligram orally, then you give 20 milligram subcutaneously and 10 milligram intravenously. So this is a conversion factor when you're changing from oral to parenteral route. Now, this intravenous, if you're giving, it can be given as a continuous infusion for continuous pain. But if there is incident pain or breakthrough pain, you can give, there's an option for an intermittent bolus. Okay, that is called patient-controlled analgesia, where both continuous pain, there's a basal infusion going on, and then you have added a for bolus dose can be given for an incident pain. So there are these pumps available. These are disposable elastomeric pumps in which there is a balloon in which you fill up the opioid infusion and there is a remote and the basal infusion will be going on at whatever rate that has been prefixed. But whenever the patient has pain, they can just press this button and they can get an added bolus dose. Or there could be what is called, these are not disposable, they are called CADD pumps. That is continuous ambulatory drug delivery. Again, this also has a remote attached. The drug is added into the small thing which is inside a capsule inside this machine, and it will be giving continuously based on the rate that you have selected. And then you can give a continuous infusion for the bolus dose for the breakthrough period. Now, there is no evidence of the superiority of parenteral versus oral opioids, but the European Association of Palliative Care recommends the use of parenteral opioid infusions where oral or transdermal opioids are not providing adequate analgesia. So they have recommended parenteral opioid infusions. Now we come to the next opioid manipulation, which is opioid rotation. And this is commonly done when there's an opioid-induced neurotoxicity. So what are the symptoms of that? The symptoms are when the patient has neurotoxicity symptoms like sedation, delirium, myoclonus, hallucinations, hyperalgesia, or seizures. These have to be explained to the relatives of the patient so that any sign of neurotoxicity they should report to us. And the cause of neurotoxicity are the metabolites of morphine, which are morphine 3-glucuronide and normepiridine. So, what do? We are using this different opioid, but the same route. For example, the patient is getting oral morphine, you can convert to oral methadone. Okay. And what are the indications? One I said is neurotoxicity, and the other thing is poor analgesia despite adequate titration. That is because of the tolerance that the patient is. How does opioid rotation work? Opioid rotation works because normally there is a cross tolerance among the opioids. Okay. For example, you're giving morphine and you're giving pethidine maybe, but even pethidine will not work because of the cross tolerance. But what is happening is there is an incomplete cross tolerance. That means there are some receptors that are still available when you're giving another opioid. That is what is called incomplete cross tolerance. So we have a greater than anticipated potency when you're using another opioid. Okay, that is the rationale between why we are doing an opioid rotation. Now, what is the commonly used drugs are methadone and fentanyl are the only other opioids of the step 3, which is available in India. Now, methadone is inexpensive, can be given orally, but both these drugs are under the same legal control as morphine. Okay, they come under the NDPS Act. So, what about methadone? I think this must have been dealt with in the earlier presentation, but just to summarize, it is very effective as a step 3 drug. It can be given for opioid switch. When morphine is not effective, you can give methadone. It's high potency. It is also effective for neuropathic pain because of its action on the NMDA receptors and the serotonin norepinephrine reuptake inhibitor. It doesn't have any known active metabolites like morphine. It has a long half-life, so the frequency of administration is less. It is slowly eliminated, and so there's a less risk of breakthrough pain. It does not accumulate in renal impairment, so it can be given in patients with renal dysfunction. Less tendency for tolerance, okay? And there is no cross tolerance. That is one advantage. So when you're giving morphine and it's not effective, if you give methadone, there is no tolerance. There's no cross tolerance. And it's also relatively inexpensive. But it has disadvantages. One is it has a high potential for accumulation and delayed toxicity. There's a risk of life-threatening ventricular arrhythmia if there is a QTC prolongation on the ECG. This is called torsades de Pontus. Titration is difficult with this drug, and only experienced palliative care specialists give methadone, not for the novice in the palliative care. So the indications are, first of all, you're giving it for opioid rotation. It's relatively inexpensive. You give it when there's true morphine allergy, for neuropathic pain and renal dysfunction. Okay. The contraindications are when there's a QTC prolongation on the ECG, no reliable caregiver, when there's history of sudden unexplained death in the family, probably a cardiac cause, then you don't give it, or there could be drug-drug interactions with azithromycin, fluconazole, and amitriptyline. So when you convert morphine to methadone, you see what is the oral morphine equivalent. Okay. So when a patient is getting less than 60 milligram of morphine, the equivalent dose is 2 to 7.5 mg per day. If he's getting between 60 to 199 morphine, and if he's less than 65 years of age, then the conversion is 10 is to 1. That means if the patient is getting 10 milligram morphine, then you give 1 milligram methadone. So you have to, that is how you calculate it. Like for example, if the patient is getting 60 milligrams morphine, then you give 6 milligrams methadone. Or if the morphine is more than 200 mg, then the conversion factor is 20 is to 1. That means 20 mg morphine, then 1 milligram methadone. This is also done when the patient is more than 65 years of age. Now, methadone is available as 5 milligram tablets and also as syrup, 5 mg per ml. Now, as per an expert consensus white paper, the equianalgesic dose suggested for methadone are very conservative and we need not occur for incomplete cross tolerance. Okay, so what I've said earlier can be given like that only. Whereas when you're converting from other opioids, then you have to actually decrease the dose, recalculated dose. I'll talk about it later. Okay? But with methadone, you can just go by what I had mentioned earlier. So this is what I'm talking about. When you're converting like from morphine to fentanyl, after calculating the equianalgesic dose, because of cross tolerance, you need to reduce it by 50% for well-controlled pain and 25% for poorly controlled pain. And the exception is methadone. For that, you don't have to decrease it to account for cross tolerance. We also need to prescribe a rescue dose. Remember, when you're giving 60 milligram morphine, the equianalgesic dose of fentanyl is 25 mics per hour. So that is the equianalgesic dose, morphine and fentanyl. Now, buprenorphine is another strong opioid. It's also a good option for opioid rotation. It can produce good pain relief. It can control neuropathic pain and breakthrough pain better, good tolerability, and it's available as transdermal patches as well as sublingual tablets. The patches come in a strength of 2.5 mics per hour, 5 mics per hour, and 10 mics per hour, even 20 mics per hour. It usually, one patch lasts for 7 days. Sublingual tablets of 200 mics are available. The duration of action is about 6 hours and is usually given for breakthrough pain. If you want to convert morphine to buprenorphine, I had already mentioned about morphine to fentanyl, morphine to methadone, and now it's morphine to buprenorphine. So if your patient is getting less than 30 milligram per hour per day of morphine, then you can start with a 5 mic per hour patch. If it's between 30 to 80, then 10 mics per hour patch. You can also, if there is a breakthrough pain, then you can supplement with immediate release morphine, sublingual buprenorphine, or even a non-opioid analgesic. But if the patient is getting more than 80 milligram morphine, then you have to be very careful because even a 20 mics per hour patch may not suffice. Now, having talked about breakthrough pain, what is breakthrough pain? That is another thing that is causing a lot of pain in cancer patients. This is described as an intermittent episode of extreme pain which breaks through the opiate regime that the patient is on. It can be both spontaneously or without any movement, or it can be induced by movement, like weight bearing on the leg or, or coughing or sneezing or even physiotherapy, etc., can cause the breakthrough pain. The incidence is 40 to 80% in cancer patients. What do we do for breakthrough pain? First of all, you have to give a fast-acting, short-duration opioid. Okay. For that, you can give either immediate release morphine or sublingual opioids, which can be either fentanyl or buprenorphine. I mentioned both of it. So, immediate release morphine, how much do you give? You can either give it as 10% of the total morphine dose per hour. Like if the patient is getting a total dose of 60 milligram, you can give 6 milligram for breakthrough pain every hour. Or you can give 50% of the 4-hourly dose. If the patient is getting 10 milligrams every 4 hours, then you can give 5 milligrams as a for breakthrough. Then alternately, you can use transmucosal fentanyl citrate or fentanyl lollipop. It's available as 20 mics and 400 mics, but do not give more than 4 units per day. It should be sucked and not chewed and over 15 minutes by the side of the mouth near the buccal mucosa. Effect starts in 30 minutes and it lasts for 2 to 3 hours. Alternately, you can also use sublingual buprenorphine tablet available as 200 mg. Now, having talked about the pharmacological options, the next thing is we need to review the cause of pain. Is the pain nociceptive or neuropathic? Or is there any need for any further adjuvant drug? So if you look at the pain pathway, which I've shown in my earlier presentation also, nociceptive pain is what is happening here, right at the nerve ending. Okay, that is where the nociceptors are. So that is because of tissue injury. Anything beyond that, first order neuron or the second order neuron or the spinal cord and up the pain pathway, anywhere here, it is a neuropathic pain. But very often, cancer pain can be mixed, both nociceptive and neuropathic. So you need to give both the drugs for the treatment of. So ketamine is one of the drugs that is used for difficult neuropathic pain. When standard analgesic options have failed, it's a reasonable third-line option. It acts at the NMDA receptor, which is situated in the dorsal horn of the spinal cord, and it is usually given when it is unresponsive to antidepressants or anticonvulsants. How are the so many routes of ketamine administration are there, starting from transdermal, intramuscular, subcutaneous, oral, sublingual, intranasal, rectal, intrathecal. So many routes are available for ketamine. Okay. It is an analgesic in subanesthetic doses. It can be given orally in a dose of 10 to 25 mg TDS or as an infusion, a maximum dose of 200 milligram per day. This has to be given in a daycare facility. There's another thing called burst ketamine or pulse dose of ketamine administration for refractory pain, in which you start off with 100 mics per 24 hours for 3 days. If it's not effective, you step it up to 300 milligram per 24 hours for another 3 days. If that is also not effective, you can go up to 500 milligram per 24 hours for 3 days. Okay. And if it's not effective with that, then there is no point in giving it. But this can be useful for certain cases of intractable neuropathy. There are side effects. I mentioned this earlier. I won't go through this. The other drug that is given for difficult neuropathic pain is local anesthetics. They act by decreasing neuronal excitability at the level of the sodium channels, and it's quite good for difficult neuropathic pain, particularly the severe intractable crescendo kind of. Can be given as a local anesthetic infusion. You give 5 milligram per kg, calculate the total dose, add in 500 ml of normal saline, and give it over 1 hour. But with cardiac monitoring and monitoring for the side effects of local anesthetic. Then also you can give as topical local anesthetic. Lidocaine patches are available. 5% lidocaine patches are now available, and you can apply up to 3 patches at a time, but only keep it for 12 hours, and the next 12 hours, the patches should not be there. Otherwise, there could be local anesthetic toxicity. The other topical drugs to treat neuropathic pain are topical capsaicin. It's not available in India freely. The 8% is not available, or topical gabapentin. So these can be used as supplements to treat the neuropathic pain. So if you look at the neuropathic pain ladder, the first line of treatment is antidepressants, anticonvulsants, duloxetine, which is SNRI, and lidocaine patch. The second line are the opioids like methadone and tramadol. And the third line are baclofen, mexiletine, capsaicin, ketamine, and cannabinoids. Now let's talk about cannabinoids in difficult cancer. Cannabinoids have been used since ancient times. But in medicine, Its use is restricted because of the legal and social concerns because of drug misuse. This is also coming under the purview of the NDPS Act. But a few symptoms in cancer patients may be resistant to the current options that are available. So, although there is no robust clinical data, but there has been a favorable risk-benefit ratio, but it is still not routinely included in palliative care. So we must remember that these cannabinoids act at two receptors, CB1 and CB2 receptor in the central nervous system. CB1 is the one that causes the psychotomimetic effects of cannabinoids, the euphoria and the high that you get. Okay, and these receptors are found in the brain, spinal cord, and all those places. But they're poorly expressed in the brainstem, and that is the reason there is low incidence of respiratory depression with cannabinoids. The other receptor is a CB2 receptor, which is mainly in the immune system. It has no psychotomimetic effects. And these have been now being investigated for its analgesic, anti-inflammatory, and anti-neoplastic effects. So the two phytocannabinoids that have been extensively studied are the THC, which is tetrahydrocannabinol, and the CBD, which is a cannabidiol. Okay, so just remember the two that we are generally using are THC and CBD. Now, nabiximol or Sativix is an oromucosal spray containing a 1:1 combination of THC and the CBD. Okay, this has been found to be well tolerated with improved analgesia in opioid unresponsive cancer patients. It's an oromucosal spray. So the preparations that are available are the THC. THC, I told you, causes a psychotomimetic effect. The synthetic drugs that are available are dronabinol and nabilon. Okay. And the combination of both are nabiximol that I discussed earlier. And the CBD dominant cannabinoid available are the cannabidiol, that is oil, 99% pure oil, can be given orally in a dose of 5 mg per kg, okay, per day. Now, all these drugs have got a high potential for abuse and come under the Schedule 1 drugs. So, cannabinoids can be used. Its effect is comparable to the weak opioids. And it can last for about 6 hours, the duration of action. It can be used as a third or fourth line treatment for neuropathic pain when conventional treatments fail. It's also been used extensively for chemotherapy-induced nausea and vomiting. They are the dronabinol and the nabilone. Okay. So I won't go through this because this is not in our... The side effects of cannabinoids. They are the neuropsychiatric ones, which can aggravate anxiety, schizophrenia, depression. There could be impaired cognition. There could be a risk of infection, and also the cardiovascular complications like hypertension, hypotension, tachycardia. So whenever there's heart disease, you avoid cannabinoids. So what is the role of cannabinoids in palliative care? Firstly, like I said, it's used as a third and fourth line drug for neuropathic pain. It can be used for chemotherapy-induced nausea, vomiting. It can be used for cancer anorexia, for HIV-related cachexia, for multiple sclerosis-induced spasticity. It improves mood and antipsychotic effects. And also it has anti-cancer effects. It can help with sleep disorders, but it can also cause seizures. In a recent article about 2 years ago, this article was the medicinal cannabis is shown to reduce pain and need for opiates among cancer patients. Okay. So they found that it significantly improved the pain measures with a decrease in cancer-related symptoms, also, other symptoms. And also it reduced the consumption of opioid-based analgesic with a minimum of side effects. So this may have a role in some cancer. But is the use of cannabinoids legal in India? What is the current status? Now, we all know that abroad it is available and approved also to treat pain due to multiple sclerosis and refractory pain and cancer. In India, the trade and consumption of cannabis is banned under the NDPS Act. There has been petitions filed calling for legalizing its use for medicinal purposes. And this voice has grown stronger over the years. And in January 2022, the center told the Delhi High Court in response to that petition that the use of cannabis is not completely banned in the country and its medicinal and scientific use is allowed under the law. So that is a good thing, It's permissible for medicinal and scientific use. So another very important drug that we can give for refractory pain is steroids, particularly when it's neuropathic pain, bone pain, headache because of metastasis, arthralgia, when there's a obstruction because of intestinal obstruction, or pain from spinal metastasis. The drug that is commonly used is dexamethasone, which has a long half-life, so it can be given only once a day. And it has also got a potent anti-inflammatory effect as well. It is very useful for malignant bowel obstruction. It has less mineralocorticoid effects, but it can cause insomnia, so we give it in the morning. It has been found that those with less life expectancy, you can provide short-term relief of pain in such patients, the terminal cancer patients. The other drug is a GABA receptor agonist. I mentioned last time about the two receptors, GABA A, GABA B. GABA A includes the benzodiazepines, out of which clonazepam is the one that we are using for neuropathic pain, and GABA B agonist is baclofen. Now, baclofen has been found, it's one of the inhibitory, it causes release of excitatory, it reduces the release of excitatory neurotransmitters by binding to the GABA B receptor. GABA B is an inhibitory receptor, okay? So it is useful for refractory neuropathic pain. You can start with 5 mg and can go up to 20 milligram TDS. For bone pain, again, another important cause of refractory pain, it can be very, very agonizing and it can affect the quality of life. So this, again, I have stressed upon in my earlier lecture, corticosteroids, calcitonin, bisphosphonates, and denosumab, which is most commonly used, and of course, palliative radiation can be used to treat refractory bone. Now, for malignant bowel obstruction, octreotide has been found to be useful because this is another very important cause of refractory cancer, particularly for abdominal malignancies. So octreotide is a synthetic hormone. It's a somatostatin analog. It acts by decreasing the splanchnic blood flow, the portal blood flow, reduces GI motility, and also all the secretions in the intestine, and also increases water and electrolyte absorption. So because of all this, it can relieve the symptoms of intestinal obstruction. How is it given? We give it as a 300 mics per 24 hours as a continuous subcutaneous infusion. And it is now the drug of choice in malignant bowel obstruction, and it can be combined with steroids and IOC. So we talked about the pharmacological aspects of managing difficult pain. So what are the non-pharmacological options? We need to combine both. So this is what was described in the step 4, which includes nerve blocks, epidurals, PCA pumps, neurolytic blocks, intrathecal opioids, spinal cord stimulators, etc. So basically, they are interventional pain procedures. So we know about the PCA pump. I described it. We can give various nerve blocks, epidural blocks, neurolytic procedures using phenol and alcohol. And they can be, like I said, chemical, thermal, or surgical. Chemical is these drugs that I mentioned. Thermal and surgical can also be done. Intrathecal procedures, spinal cord stimulation. Okay. But these are considered in patients who have severe side effects from the drugs and whose life expectancy is more than 3 months. Because many of them, particularly the intrathecal and spinal cord stimulators, are very expensive. So only when the life expectancy is more than 3 months, then you can consider it. But there are other neuroablation procedures also, like neurologic block of the celiac plexus, the superior hypogastric plexus, the ganglion impar, stellate ganglion blocks, lumbar sympathetic plexus block, or intercostal nerve blocks, and even trigeminal neurons. Besides this, there are central neurodestructive procedures like rhizotomy, gangliotomy, chordotomy, myelotomy, thalamotomy, and all. But they are very rarely done, and they are relatively high risk procedures, and it's only done when the life expectancy is less than 3 months. But again, a risk benefit ratio should be assessed because sometimes the risk may outweigh the benefits of the procedure. The other non-pharmacological therapies are dry needling, which I have found to be very effective in my own personal experience, acupuncture, biofeedback, psychological therapy, physical modalities, spiritual therapy, and alternate therapies. So this is dry needling of the back. So it's used to treat, particularly when there is abdominal cancer, there can be very severe spasm, or if there's a spinal metastasis again. So this can relieve the spasm to a large extent. Then physical therapy can be useful. Various modalities are available. Then you have the psychosocial aspects and the spiritual issues which need to be addressed. Whole lot of these issues are present in such patients. So we may need to use a combination of psychotherapeutic methods, including counseling, communication, medications, support groups, and may even have to offer financial support. So coming back to the case scenario that I had discussed earlier, now this gentleman had an intestinal obstruction for which the patient had a rice tube inserted and a colostomy done, but he was still in agonizing pain. The medical reasons could be progression of the disease because the colostomy site looked quite unhealthy, or there could be a failed route of absorption. The oral route could not be given, and the transdermal route might not have been effective. But could there have been other psychosocial concerns? So what was done? He was readmitted to the hospital. The colostomy was found to be non-functional and necrotic. The site was necrotic, so that could have been the cause of severe pain. So a opioid route conversion was done. From transdermal fentanyl, he was switched over to fentanyl infusion, and supportive care was also given. The pain subsided. The end-of-life care was instituted, and this was explained to his relatives, and he expired free of pain 2 weeks later. So have they been too drug-centered or intervention-centered in our approach? Did we do adequate non-pharmacological intervention? Now, what were the psychosocial concerns in this patient? He was a highly educated retired doctor. He had no financial concerns because his cost was completely covered by insurance. He had a very supportive family with a wife and a daughter. Wife was a main caregiver and she had taken over the role of head of the family. But he had still a lot of psychosocial concerns. He was depressed because he knew that there was no cure and he would not live long. So he had a sense of hopelessness, helplessness, and powerlessness. He had other psychosocial concerns. Because of COVID and because of cancer, he was experiencing loneliness and isolation. They had withdrawn from friends and relatives for 2 years. He had a low self-esteem because he was dependent on his wife for even his self-care activities. He had guilt feelings. His family had given up all their activities. In fact, the wife had given up her job also so that she could be his full-time caregiver. So there was a sense of guilt as well. And there was a role reversal because he was the head of the family, but now his wife had taken over all his responsibilities. So these might have been the possible psychosocial concern that this gentleman had. So again, when you go to every step of the ladder, and even for the advanced management, Remember, the psychosocial concerns also have to be reviewed and addressed at every stage of the management. But if everything fails, we can consider palliative sedation. Otherwise, we have to accept failure, but we should never desert the patient. Be fellow travelers with them in their difficult journey. We can be frank about failure, but we can convey that with sensitivity and continue with the psychosocial spiritual support and treat any worsening of the conditions or any incidental problems. So that is how we have to handle. It's a very difficult thing, but it requires a lot of consideration, judgment, reassessment, and sensitivity and empathy when you deal with such patients. Thank you.
Thank you, ma'am. Thank you for such a wonderful session. And especially at the end, you have mentioned very clearly that we shouldn't be deserting the patient by telling that, we have nothing to offer. That is what we always come up with. So, thank you, ma'am. Meanwhile, ma'am, we have two questions in the chat box. Maybe we can take that. And participants, you can also post your questions in the chat box or even raise your hand. So that till maybe like for another 10 minutes, we can take questions and then move to the case presentation.
Okay, the first question is where we can get training for dry needling. Okay, now dry needling, physiotherapists are also doing dry needling, but that is very different from the dry needling that we people do, the pain specialists do. Because physiotherapists know if there is a trapezius muscle, they'll put one needle, they may twirl the needle, and they don't insert more than one or two needles per person. Whereas we people can insert anywhere between 50 to 100 needles for pain. Okay, so we need, it's done by doctors because we have a maybe better knowledge of the anatomy and the muscles, muscular anatomy. And being doctors, we can handle the problems also if there is a problem, which is usually very rare. So pain specialist dry needling is different from what the chiropractic and the physiotherapists are doing. Because now all of them are doing dry needling, but their dry needling is very different from what we do. So the training can be very few people are actually offering. Nowadays in our conferences, pain conferences, we have been having workshops. Last 2 years, Amritsar and again Pune, we had dry needling workshops. So I would suggest you can start off by attending one of those workshops in the conferences. But the dry needling, if you want to really learn it earnestly, then in Bombay, there is Dr. Lakshmi Vas, who is uh, having this Institute of Pain Management, Ashirvad Institute of Pain Management. They are having proper courses in dry needling also. That's one place where you can learn dry needling. But there are very few people. If you look at in Delhi, I'm living in Delhi. I don't know many people who do the kind of dry needling I do. So, and also in other places, even in metros, not many people. Bombay, Pune, I know because people who have trained under Lakshmi are going back to their places and doing dry needling. So, I also got trained by Dr. Lakshmi only. So, that's that. But you can start off by attending a workshop in one of the pain conference, annual pain conference. That is the IASP conference. They are now having routinely dry needling workshops. Okay.
Adding to that,
Pardon me?
yes, ma'am. Adding to that question, I think the questions are more towards the course. That is for how many days, and they would like to do it.
Yeah, you can do short-term courses, but she also holds a diploma course. But for that, I think Maharashtra people are more eligible because it comes under the Maharashtra University. So there could be some problem. But there are short courses also that you can attend. You can just Google Ashirvad Institute of Pain Management.
Thank you, ma'am. There's one question. Could a patient be taught to dry needle themselves if willing?
No, never, never. I do it for myself, okay? But that's because I know my problem, I can do it. But nobody can do it themselves, never. A strict no. It
Are
has to
these
be done by trained people. Otherwise, you will land up injuring yourself and causing some complication. Otherwise, routinely, there's no complication. But if you cannot do it yourself, it requires training. And basically, interventional doctors are the ones, the pain specialists are the ones who can do dry needling.
Are these needles disposable?
All disposable. And various sizes are available depending on which muscle you're needling. Like, for example, if I'm needling the back and I'm going along the spine on the multifidus and the rotators muscle, which are adjacent to the spine, I use 40 needles. But as I go towards the buttocks and towards the hamstrings, I can use, depending on the patient, it can be 75 needles or even 100 needles, 10 centimeter long. That means in a very obese lady, I may use 100 needles in the buttocks and the hips. Okay, to actually, because you need to go along the entire length of the muscle and not just in the outer aspect of it. So it all depends upon the place where you're needling. Like in the shoulder, neck, you use 40 needles. But in the back and buttocks and all, you may have to go to longer length needles. The size of the needle is, the gauge of the needle is the same. They're all 32 gauge needles, but the length can vary and they're all disposable.
Thank you, ma'am. One question from Dr. Aditi. Why palliative radiation cannot be considered for pain management? Not for
Can
this,
be
but
considered. It can be considered if it is localized. See, radiation has to be given in a particular place. If there are multiple metastases along the spine, how can you do radiation? But if it is localized, you can definitely treat it with radiation.
is there any contraindication for using steroids
Or
like hemorrhage? Is there any contraindications for using steroids like hemorrhage? It's a question from Dr. Raisa.
1 minute. Is there a contraindication?
For using steroids.
See, if the patient has got acid peptic disease, whenever you use steroids, you have to use one of the antacids like pantoprazole and all. Never give it without using that. It has to be given in the morning because it can, if you're given in the evening, you can cause insomnia, right? And it is given, if you're giving dexamethasone, given as a single dose. But if the patient has history of bleed, GI bleed, or that's the one of the only contraindications, I think, when there's a GI bleed, then you have to think twice about giving. But always give it with one of the drugs like pantoprazole or rabiprazole, one of them. Never give it without that and after food. Otherwise, see, steroids, we are routinely giving it in brain tumor patients. Okay. In brain tumor patients who have got severe headaches and those with metastasis, it is reducing the perilesional edema. Means around the mets, whatever the edema is there, that can significantly come down with steroids. So it is routinely given in our brain tumor patients. Spinal metastasis, again, very useful. Malignant bowel obstruction, very useful. So you have to, even in bone pain, sometimes it can be very useful. So you have to weigh the pros and cons, but there's a history of GI bleed, then you have to be a little cautious when you're using steroids.
Dr. Raisa, would you like to unmute and ask? Because I can see that you have raised your hand.
And I
Ma'am,
have
it's
like
comment.
regarding the
Ma'am,
same.
it's Dr. Rusa here.
Pardon me?
Ma'am, it's Dr. Rusa. Ma'am, in our setting, we are using low dose of steroids, like for bone pain, patients are coming. So we are using steroids.
Yeah.
Parent, we do give. As
Yeah.
it reduces the edema, so we use. Very often we use. Yeah, taking care of like GI bleed patients, but very often we use in order to decrease edema, inflammation. We do use steroids.
Very potent anti-inflammatory drug.
Yeah.
So that is why it's used for malignant bowel obstruction and brain tumors and so
Yes,
many
ma'am.
places where there is.
Grams to 16 milligrams dose. That's it.
Yeah.
Like
See,
single.
it depends. See, if the dose depends upon the problem that is there. Okay.
Yeah.
So sometimes you can go up to 16 mg. Sometimes you can stick with 4 mg or 8 mg dexamethasone. Okay.
Yes.
It depends upon the underlying problem.
Yeah. Thank you, ma'am. Thank you.
Raisa?
Yes, ma'am. Actually, in case of like CA lung with bone meds and all, the maybe steroid will help for bone pain. But is if there is hemoptysis along with that, is there any contraindication is in giving steroids in such cases, ma'am?
Hemoptysis may not be a problem. It's the
Okay.
GI bleeds that are more of a problem.
Okay.
Okay. I don't think hemoptysis can be a problem.
Okay. Thank you.
Thank you, Dr. Aiza. So there's one more question, ma'am. With respect to dry needling, how instantaneous is the effect and how long does it last for? Any role in breakthrough pain instead of a bolus dose?
The effect of dry needling depends upon what you're doing. If you're treating acute back pain, a patient has suddenly developed back pain and the muscles are in spasm, even with one session, you can get permanent good relief with that. Now, if a patient is coming with sciatica, long-standing sciatica, 10 years, 5 years duration, and severe back pain, it will take longer. You may have to use 5 to 10 sessions before you can get good relief. But if it is an acute condition, like sudden spasm and or a disc prolapse, I've even given it for disc prolapse patients. We can manage to do dry needling for that. So the idea is whenever there's a disc prolapse, there is a nerve compression, but in addition to that, the muscle spasm can worsen that nerve compression. So you're treating the muscle spasm. And there are many times I found that even with slip disc, if you use the medications like pregabalin along with the dry needling, you can get very good effect. I've treated many people like that. So it's releasing them. It's a very potent releasing of muscle spasm because the needle is going right into the muscle and it's just releasing that muscle. Okay. So its effect can be very sustained. Let me tell you that. I've had many patients who have not come back to me again because they have had, even with sciatica, they have had very good relief with dry needling. It can be potent when it is effective, and any role in breakthrough pain instead of a bolus dose. No, I don't want to mix up the two. When you're giving morphine and breakthrough pain, I think we should stick to a medicine only. But definitely, it can help with if you're treating in a non-pharmacological way. It is very effective.
There's one more question from Dr. Aditi, ma'am. In bone
Aditi?
metastasis.
Aditi.
Yes, ma'am, Dr. Aditi.
Okay.
So in bone metastasis patient, can we use dry needles and also for other cancer pains, just dry
Yeah.
needling?
See, wherever there is muscle spasm, supposing that there's a metastasis in the spine, there will be associated muscle spasm. So the muscle spasm can be treated, and muscle spasm is a very important cause of pain. Even in pancreatic cancer, they complain of pain radiating to the back. You can use dry needling in those patients. Just the back muscles have to be needled.
Okay, ma'am. Thank you, ma'am. As of now, I think we have answered all the questions in the chat box. So maybe we can move with the case scenario, the case patient story for today. So we have Dr. Somadatta joining us for the case presentation. It's over to you, Dr. Somadatta. Welcome you.
So, hi, hello everyone. Good afternoon. I'm Dr. Soma. So this is the case. You're sharing the slides. Yeah, thank you. So the patient is 73 years. She's a female. Diagnosis: degenerative disc disease of the lumbosacral spine, causing severe lumbar radiculopathy on the right side, severe osteoporosis, osteoarthritis right knee, and chronic B hepatitis infection. Her presenting complaints were reduced appetite, fatigue, and sleep disturbance since the last 6 months. Severe pain at the back of right hip region radiating down the right leg since the last 10 months. Pain right leg and lower back on prolonged standing or walking or weight bearing since the last 2 years. History of illness. She has history of sudden twisting of the right knee 2 years back on the road. Since then, she keeps complaining of right knee pain intermittently. She also has history of diagnosis of chronic hepatitis B infection 1.5 years back. After her skin patches on the lower legs, lower back, abdomen were investigated. She has history of being diagnosed with osteoporosis 5 years ago, and she was then put on tablet alendronate. She has intermittent pain in the right hip region with a pain score of 9 by 10, radiating down the back of right leg, starting suddenly in the middle of the night, on an average of 4 to 5 days in a row. The excruciating burning kind of pain, which keeps awake at night, lasts throughout the day, though reduced in intensity, and worse during, I can't read that, one second, sorry. And is, I can't, the excruciating burning kind of pain which keeps her awake at night lasts throughout the day, though reduced in intensity, and it's worse during, next slide, I can't read the last slide. Okay. On clinical exam, she's a thin, small build patient, BP 94 by 56 mmHg, pulse 72 per minute, temperature normal, 98.4, respiratory rate 18 breaths per minute, cardiovascular system normal, respiratory system normal, gastrointestinal system normal, liver not enlarged, spleen not palpable, nervous system normal. On the skin, she has irregular grayish black, about 2 mm to 6 mm in size, scattered over the skin of the lower back, overlying the lower thoracic and lumbar spine, the abdomen, forehead, and few on the cheeks on both sides. Next slide, please. Her recent investigations done in February 24 show hemoglobin 10.2, her CBC, renal function test, liver function test, and thyroid function test are within normal limits. Her calcium, phosphorus, electrolytes are also normal. Vitamin D is within normal limits. A vitamin B12 is raised, 1410 picogram per ml. Her bone mineral density reveals severe osteoporosis. Her MRI lumbosacral spine, bilateral sacroiliac joints, and screening of the spine shows multi-level cervical and lumbar degenerative disc changes, including disc osteophyte complex, disc protrusions, and thecal sac indentation with neural compromise at lumbar vertebra 3 to 4 and lumbar vertebra 4 to 5 levels. Next slide, please. Yeah. Drug and treatment history. She had been prescribed various painkillers over time, but was found to be intolerant to ibuprofen, diclofenac, paracetamol, tramadol, and pregabalin because of adverse reaction side effects she had, like hypotension, severe giddiness leading to fall, stomach tablets which she was taking earlier. She discontinued calcium tablets for a year because of colicky pain due to renal stones. She was initially on tablet alendronate 70 milligrams weekly for years, but now it has been stopped and she has been started on injection denosumab. She was on tablet methylcobalamin, but now that also has been stopped due to elevated B12 levels. She continues to do yoga and also the exercises advised by the physiotherapist. Next slide, please. Oh, God. Yeah. Aspect. She's a 73-year-old woman living with her 80-year-old husband. Pension. Husband has history of multiple health issues like CVA, CABG, mitral valve replacement, lumbar canal stenosis, incisional hernia, type 2 diabetes mellitus, hypertension, aspirin-induced gastric ulcer, etc. And he has severe mobility issues. He needs to be taken to the hospital every 15 days for his blood test, like the INR, etc. She also has a 50-year-old unemployed divorced daughter living with them for the last 3 years. She is on psychotropic drugs and thus needs to be monitored and taken to the psychiatrist every month, sometimes even earlier. She was very active till 2 years ago, managing all the household chores, managing all the household chose and taking care of her husband and daughter. But now she lie down in bed most days with pain, thus affecting her daily life. She also worries about her daughter's health and her future. Next slide, please. Yeah. Her present medications include tablet entecavir 1 milligram daily, soft gel capsules of calcium and vitamin D, tablet glucosamine chondroitin sulfate, capsule iron folic, injection denosumab subcutaneously every 6 months, which was started recently after stopping tablet alendronate. And she's also presently on Ayurvedic oils for external use and Ayurvedic medicines like ashwagandha, bringraj, etc. for oral use. The main concerns in her case, they're the debilitating hip pain, the knee pain, the lack of sleep, lack of appetite. Summary: 73-year-old female with chronic hepatitis B patient with severe osteoporosis, osteoarthritis right knee, and multi-level degenerative disc disease of the lumbosacral spine, experiencing excruciating nocturnal pain right hip, leading to fatigue and chronic insomnia. Next slide, please. Discussion points. How can we manage her pain effectively without causing adverse reactions? How can we improve her sleep, appetite, and quality of life in general, considering her osteoporosis and hepatitis B infection alongside her pain issues? How can we provide her with psychosocial support to help her cope with her emotional and mental stress of her condition and also of her caregiving responsibility? Thank you.
Thank you, Dr. Somadatta, for bringing a difficult case for discussion. Meanwhile, participants, you can also post your comments regarding this patient story in the chat box. And Dr. Somadatta, you can also, mention how you found it difficult to manage this patient, because you have seen that patient directly. Maybe you can add points on what all went difficult for you in managing this patient, especially. From that, we can start with the discussion.
Okay.
And we have Dr. Mary ma'am also here to support us.
Yes. So this patient, she's a very positive patient, and she's she's full of life. She used to be till about 2 years back, and she was very active. She would not sit and she's very thin built. So her BP, low BP is also an issue with her actually. So when she had this, she used to take this paracetamol sometimes, and she would be okay. This wasn't that bad. But after this hepatitis B was diagnosed, thereafter it has been observed, like even last month also she had taken a tablet of paracetamol, but this time even paracetamol she could not tolerate, and her main problem is she keeps vomiting and she is dizzy and her BP drops so low that she has to be like given salt solution and injections for vomiting, admitted for a while, and then she's back home, then she's all right. So after giving like diclofenac and paracetamol, these things were started. Even tramadol was started. So even she took half a tablet. She was so scared to take because of all these problems. Like generally she thinks my painkillers I can't tolerate. So now even with that half tablet of tramadol, she had such a bad episode of giddiness and vomiting that now she's like scared to take. So I was thinking about the steps of the ladder. So first step is already out. What I could think of is maybe we haven't tried any adjuvants first line adjuvants or the first line treatment of that neuropathic pain ladder. So adjuvants like maybe not get her advice. So I think that is a suggestion. Maybe that also it will also take care of the anxiety and the depression part presently what she's experiencing with all this. She's not so positive anymore. So I find that difficulty in the treatment, that now it is very difficult to make her for her compliance, like she may take or she may not take orally, but what other option we have? Initially, we have to start oral.
Yes. So there's a comment from Dr. Ravindra who says add clonazepam. Yes, participants, you can also post your comments. You can just imagine this case, patient story, and then you can add your comments on that so that it will be helpful for others. And Mary ma'am, would you like to add your points on this?
I just wanted one clarification. Is that what is a liver function
ma'am.
test like? Is a liver function
Liver
abnormal or
function,
normal? Is a hepatitis B infection
uh,
under control?
uh, this was done about 1.5 years back. So the gastroenterologist said no need to repeat it so early. She's on that tablet entacavir. So
Yeah.
they said they will check after 2 years. But her routine, the LFT, the albumin proteins, the alkaline phosphatase, the SGOT, SGPT, they are normal. But she has been told to do ultrasound and LFT every 6 months. That she's doing.
Okay. And but she's not tolerating paracetamol also.
No, earlier she used to take, but now I don't know what happened. She vomited so bad with the paracetamol last month that now I don't know what to give her. And she's worried that something happens to me. There's nobody to take care of the husband and that daughter because she's also patient.
See, basically in this
Yeah.
lady, we have to look at entirety, not just physical pain. She has a
Yes,
lot
ma'am.
of psychological and social issues also.
Yes.
Looking after, she feels she's
Yes,
the one
ma'am.
taking care of her husband and her daughter. Huh? And then
She was,
also the
yes,
daughter has also some psychiatric problem
yes,
also.
yes,
And
yes,
the other
yes,
thing
ma'am.
is that, she herself has now become a little incapacitated and not able to sleep well and
Yes,
anxiety. So I feel
yes,
that we have to address in totality, including her
yes.
physical as well as her other issues have to be addressed. But even for the physical point, I feel that we are not so far added any anticonvulsant or antidepressant
No,
to
no.
her regime. See,
Yes,
she
I
is
think.
having a spine degenerative issue.
Mm.
Okay, and it is not pointing according to the MRI. There is no right-sided pressures. So it is more, they are saying, very generalized kind of a degenerative lesion. Because if a pain is
But
on the right side, there should have been, the MRI finding should have pointed to the right nerve root.
uh, ma'am, she gets on the left side, but left is not that bad. Like I said, normally she's a very positive lady. So right side is very debilitating. Left,
Mm.
she says it's minor. Sometimes it's okay, tolerable. So she mentions only the right part. It is there mildly on the left side. It's not that bad.
Okay.
But
But
doctors
so
couldn't
she
find out.
definitely needs to be started on an antidepressant, anticonvulsant also.
Yes, yes,
So
that's what
that
I
has, because she's complaining of burning pain. Burning
heard.
pain happens when there is a neuropathic element.
Yes, ma'am. Yes, yes,
Tingling, burning, numbness,
yes,
all that means
yes, ma'am.
indicates a neuropathic component. So
Yes.
I feel that that has to be added along a combination. You may
Mm.
have to add both pregabalin, gabapentin with amitriptyline or nortriptyline, both.
Ma'am, sorry to say, she couldn't tolerate pregabalin,
Mm.
and she's presently on gabapentin, but that is not helping much.
See, whether it's helping much or not, we have to give it. Okay.
Yeah. She's
See,
on.
there
She's
are
on for the
people who
last
will
two
say
months.
this doesn't help me, but
Yes,
they have
yes.
to take, and not only, and start, her weight is how much? What is her weight?
Her weight is 43 kilos.
So we have to start with the dose of 100 mg gabapentin. If you give her 300 mg, it may be too much for her. Okay.
Yeah,
She's not
she's taking
tolerating
gabapentin.
because we are giving her a higher dose than what she's requiring. 43 kilos means
Mm,
she get, just start with 100 mg gabapentin and add 10 mg tryptomer or
That I think. She's
or
on
not.
gabapentin 100 mg, ma'am.
Mm.
Pregabalin she couldn't tolerate 75 pregabalin. So gabapentin 10 is being given for the last 3 months, and this
Gabapentin
has to
100
be.
mg.
Yes,
100.
yes, she's on. She's already on that. But this anticonvulsant, this not triptyline hasn't been tried. So
That can be
I think
started in
yes,
10
yes,
mg. Start off with 10 mg.
10 mg, yes,
And every 5 days, after 1 week, you can increase it.
yes.
See,
Okay, ma'am. Yes,
it's not a static dose.
yes,
Gabapentin 500, say we start with 100. After about 1 week, make it 200 mg. Okay.
Okay.
So you have to titrate it and start it. You know? And
Yes.
also she should take it before 8 o'clock at night. Okay.
Yes,
Because
ma'am.
otherwise the residual somnolent effect will be there in the morning. So
Yes, ma'am.
I tell all my patients, give it at 7:30 at night. Okay,
Okay.
don't take it at
Okay,
10:30,
ma'am.
11 o'clock or
Yes,
whatever
yes.
the time they have their dinner.
Yes, ma'am.
That's too late. So
Thank you,
this
ma'am.
definitely has to be added. In
Yes.
addition, for the sleep, like the clonazepam is a very good idea. Clonazepam is one drug that is not only an antidepressant, but it can also anti-anxiety, and it is good for neuropathic pain. It's a
Okay.
GABA A agonist, which
Hmm.
is good for neuropathic pain. So I think clonazepam is a good drug to relieve anxiety, cause sleep, as well as to some extent relieve the neuropathic pain. Start with
Okay.
0.25 mg at night.
Okay.
Okay.
So these two, yeah.
So these
These.
are the drugs that need to be given. In addition, you have to again tell her that paracetamol, one time you vomited doesn't mean that you will have a problem. It's very rare that you have a problem with paracetamol. The other option
Hmm.
is tramadol. Okay.
Hmm.
Go on to weak
Tramadol,
opioids.
ma'am, she vomited. Half tablet of tramadol, she vomited.
Tramadol can cause vomiting. I think paracetamol is not a bad idea. You can give
Hmm.
paracetamol along
Hmm.
with a muscle relaxant also. Like
Hmm.
Myospaz has got
Hmm.
chlorzoxazone and paracetamol.
Yes,
I
yes.
find it
Yes,
very
ma'am.
effective for many of my patients.
Okay.
Okay. So
Okay,
that
ma'am.
is about the medical aspect. Regarding the other aspects, see, we have to give a psychosocial support. And
Hmm.
that's where the psychosocial worker can help, you know, help her handle her other responsibilities at home. Okay.
Hmm.
And
Yeah.
reassure her that we are with her, give her the support that she needs. She may be feeling lonely, you know, because husband,
Hmm.
daughter, both not well. So that kind of social support has to be given to her, saying that we'll help you if there's a problem, you know. And also another thing I noticed, she's on denosumab. You're
Yes, ma'am.
saying that her financial status is not that good.
No, this he's a pensioner, so he was in the government service.
You know,
So government is paying. They have
denosumab
this
treatment
empaneled.
comes to 1 month of denosumab
Yes,
costs
ma'am.
36,000.
He was
So
the railways, ma'am. So the government is paying. Government
oh,
is paying. So that
the
she's part of
government is
it.
paying now. That's
That is
fine.
right.
That's fine.
In
Then it's
fact,
fine.
the orthopedic first he said we'll give that teriparatide every day. But then
I know
she
that.
said I cannot take it every day. Then he made it. 6 monthly will give this. So now she's on that. So alendronate because she had taken for more than 5 years, so it was stopped. So,
So
ma'am, thank you
see,
so much. Actually, yeah,
okay.
I really
See,
know
one is
this is a
osteoporosis. She has osteoporosis. She has
yes, yes,
osteoarthritis. She has got a spinal degenerative problem.
yes.
Okay.
Okay.
Osteoporosis treatment is being given.
Mm.
Osteoarthritis, it depends
She's
upon the
doing
X-ray,
yoga.
how bad it is, you know, and
Mm.
things like that. We have to see what is the X-ray of the knee. And
Uh,
again, for this lady, I would have given her dry needling. Okay.
I was thinking of dry needling, but I don't know where like
I've treated many of such patients with dry
okay,
needling. Even osteoarthritis knee, you can treat with dry needling.
okay. That is new, something new to hear. Oh, so nice. So north side, madam, other than Delhi, do you have anywhere in like Punjab, Chandigarh, that side? Because nothing, no, that's and what about
Bombay, there
Goa
is. Bombay,
somewhere?
there is.
Bombay there is. Okay.
Pune, there is.
Okay.
Pune also.
Achha, Pune you
Because
have.
many people have gone to Pune and they're doing dry needling. And Delhi also,
Okay.
very few people are doing it. You know, I don't know.
Ma'am, if you have the addresses or contact number of those
You can just
places,
Google,
can
no,
you send?
Ashirvad Pain
Okay.
Institute
So
and
all
Dr.
are
Lakshmi
by
Vas.
okay.
Huh?
All are her centers only.
She's got
All
one
these.
center only.
Okay. Okay, ma'am. Thank you so much, ma'am, for the overall picture of overall. It's a complex psychosocial, like you said, everything has to be taken care of. So
Yes.
yes, I will try. Thank you,
She
ma'am.
will also need, since whether her relatives can support her to a certain extent, sister, brother.
I have tried talking to her and the husband, but they have their. She says there's nobody like that who will help if I ask, and I don't know to ask. So these things, let us see if we can. Then otherwise, you have no option. Then you have to think of that also.
Yeah.
That I have suggested.
Any
Okay.
other doubts from anybody else?
There are a few comments in the chat box, ma'am, from Dr. Shilpa saying that counseling is required, and Dr. Kalyani saying that husband also requires palliative care considering his age and all the medical comorbidities that he has.
Effect of the dry needling can be quite good. Okay. It
Yes,
can
ma'am.
last also, sustained effect it can produce. So the idea of dry needling is improving even the functionality of the person. Like people who have got, they're able to walk around and more activities with their hands, with their, not only the pain is decreased, but disability is also decreased.
All that spasm is gone. Yeah, I will suggest that, ma'am. Yeah, I will mention that. Anything else?
Dr. Aditi, you had posted a question in the chat box previously. Would you like to unmute and ask that? Dr. Aditi?
Dr.
Yes,
Aditi
hello.
is there?
Yes, doctor. Please go ahead. You had posted a question in the chat box previously. So can you be a bit more clear? You can unmute and ask your question.
Yeah, ma'am, this dry needling, if any malignant cases, if you are doing, so how many days it is lasting, that the pain subside for how many days, so that we can opt this
See,
treatment?
it depends upon the condition that you're treating. Like there are, say, many people who have got spinal meds and who have a
Yeah.
lot of back pain. Okay. So we give it only for the spasm to be reduced and then we to discontinue it. It may take a few sessions, 3-4 sessions. That's all that is required. Okay. Because in malignancy, particularly terminal, when there is meds and all, even the life expectancy is not much, right? So as long as they are there and, you have to add adjuvants also, like I told you, muscle relaxants, anticonvulsants, antidepressants. And
Yes, ma'am.
so this is a modality that can be added on to those drugs to treat. But there are many people who are hesitant to take it. I myself had 1 or 2 cancer patients in which I offered it, but then they wonder whether that will cause more. When there are hesitancy among the people to take dry needling, they think that it can be harmful because you're putting needles in. So that is there. But once they take it, they come back for more. I have people who regularly over the years, they come, we want to come back, we have developed some other pain, we want to get some dry needling done. So I've got my regular people who come back over the years, they come back to me. But at the same time, there's a lot of hesitancy when you explain about the procedure. They think that putting needles means it can cause some injury to my nerves or to my muscles. So it's very important to know the anatomy before and get adequate training before you try out dry needling.
Okay.
Because it is very safe in safe hands and experienced hands, but not inexperienced people.
Okay, ma'am. Yes, thank you.
I have a website, but right now it's not functioning. The minute it's functioning, I can let Gayatri know, in which I posted in my blog about patients' experience with dry needling. Okay. So once it's activated, I'll inform Gayatri. She will inform you. Some problem has happened and that my website is not working for the last couple of months. But once it is working, please go to my blogs. You can hear patients talking about dry needling and how it benefited. I posted some audios and videos and things like that. And also I've written 2 books. One is Conquering Pain, one is Managing Chronic Pain. In both, I have talked about dry needling.
Okay, ma'am. Yes. Thank you, ma'am.
You know the name of my book? I think it's there on my CV. Gayatri.
Yes, ma'am. Yes, ma'am.
So if you can just put it across, anyone who's interested can buy it, because in that I have spoken about dry needling in both the books.
Sure, ma'am. We will post it in the WhatsApp group. Any more questions? I think all the questions in the chat box have been answered. If you have any more questions, we have 4 more minutes and we can take it up. Dr. Aiza, please go ahead.
Hi, ma'am. Not regarding this case. Generally, NSAID allergy patients will be there, right? So in some low backache case and on end of pain they'll have. So we used to give NSAIDs SOS, right? In such cases, can we give step 2 analgesics as SOS doses? Like Ultracet and all. If pain is there,
See, I'll tell you, if there are medical comorbidities, then
Yeah.
I would advise you to give step 2 drugs. Okay.
yeah,
But
SOS,
if it's a young person with no medical comorbidities, okay, no allergy, no renal problems, and no cardiac issues, or then you can give NSAIDs.
Yeah.
Like if it's an acute back pain, acute sprain of the back, then NSAIDs is very effective as compared to even tramadol, because it has got an anti-inflammatory effect. Okay, so there's no harm in giving NSAIDs for 1 or 2 weeks, but not longer than that. Like
No.
chronic arthritis and all, if you go to orthopedic doctor, they're very often prescribing the selective NSAIDs. Okay, like doricoxib.
Okay.
So that is very often prescribed for patients with arthritis knee, rheumatoid arthritis. Any rheumatologist, orthopedic doctor are prescribing these only once a day dose, celecoxib, Nucoxia. It's called Nucoxia, right? So they are giving that, but even that actually is contraindicated in patients with cerebral and cardiovascular problems. You don't give that selective drugs because a history of thrombotic phenomenon. But they are giving it. So if there are medical comorbidities, then I would suggest use it cautiously. But if there are no comorbidities, healthy patient, young patient, there's no harm in giving it for 1 week.
No
Very
harm.
good.
You
Like
react.
I find patients who have had a fall and then they have got some swelling, then along with this anti-inflammatory drugs are very good. Like aceclofenac or diclofenac or even brufen. They're very good for these drugs.
No, if they're allergic to NSAIDs, I asked, ma'am.
Then allergic hai to then you cannot. Then you can go on to tramadol or paracetamol.
Okay, ma'am. Thank you. SOS dose also we can give, right?
No, yeah. Allergy is something that you have to be very careful of. If they're allergic, then we should avoid all NSAIDs.
Okay, ma'am. Thank you.
Thank you, ma'am.
Allergy you can try selective COX-2 inhibitor, okay? Because they have got less allergic phenomenon, right? But it can cause renal dysfunction and thrombotic effects that you have to keep it in.
Thank you, ma'am. I think that was answered. There are no more questions in the chat box, and I think it is 3:30 right now. Maybe we can close the session for today. If you have more questions, you can please contact Gayatri or send your questions. We can send a mail to Mary ma'am and get it back. That is also possible. But then as of now, I think there are no more questions. We'll close for today. Thank you so much, Dr. Mary ma'am, for joining us and for such a wonderful session on difficult pain.
Thank you.
Thank you, ma'am. Over to you, Gayatri.
Thank you, Dr. Mary ma'am and Dr. Hashmat ma'am for the wonderful session. Thank you all for the participation and time. I hope you all got idea about the difficult pain, and we are looking forward to see you on the next session. Thank you.